As you see, the topic I'm going to be speaking about is the guidelines for prevention of cardiovascular disease in women. And if we look at the life and age of women from the cradle to the grave as depicted in this particular portrait here, if you look at the leading cause of death of women worldwide, it is actually cardiovascular disease. It's not the cancers, although many women are under the misapprehension that is actually cancer. It's cardiovascular disease. Now, pertaining to South Africa, unfortunately, our leading cause of death is actually relating to the infectious diseases of HIV, AIDS, and tuberculosis. But if you look at the non-communicable diseases, it's actually cardiovascular disease. And worldwide, it doesn't matter where you live, whether you're in a low income, a middle income, or a high income country, the two most important causes of death are ischemic heart disease and stroke. And the importance of this is that women who live in the low and middle income countries actually have a double or an increased rate, a double increased rate in terms of death compared to those living in the high income countries. So what do we know about cardiovascular health and disease in women? And I'm going to take you back to 1993 when this publication by Nanette Wenger appeared in the New England Journal of Medicine. And to quote it, there was insufficient information about preventative strategies in terms of diagnostic testings, in terms of responses to medical and surgical therapies. And in terms of all of this, it was a lack of information due to the fact that there was no participation of women in research studies. Women who were of childbearing age had been excluded, and in terms of our elderly women, they were also excluded because of frequent coexisting illness. In that same edition of the New England Journal of Medicine, there were two special reports. And the first one was looking at the need for inclusion of women in clinical trials, policies for population subgroups. We were considered women as a subgroup. The second thing in terms of the special report was now to look at including women in clinical trials of new drugs, because the Food and Drug Administration policy prior to this time was to exclude women. There was actually a moratorium in 1976 not to have women in clinical trials. So in 1999, the first gender-specific guidelines were published, and it's not surprised that there was no evidence-based summary that existed. So what did exist? In terms of women who had had heart attacks, the advice was to treat them the same as men. And I show you here the American Heart Association consensus panel statement. This was endorsed by the American College of Cardiology and as well as the Physicians Association. And the treatments were the same, except for one thing which I've highlighted and enlarged here, and that was the use of estrogen. It was advised that if you had had a heart attack and you were a woman, consider estrogen replacement therapy in all these postmenopausal women. This had been actually advised on observational studies. So when we started having studies that were developed, randomized prospective trials, which used in fact the gold standard of therapy in the US, which was the oral conjugated equine estrogen, we know it as Premarin. You used it either alone or in combination with the medroxyprogesterone acetate. We then had some trials, and in terms of the secondary prevention trials, of which there were two, the HERS and the ERA as they were known, these trials actually showed no benefit. The HERS were women who had already had infarcts, who in their mid-60s were put onto hormone therapy, and there was no benefit. In fact, in the first year, there was an increase in events of 52%. In terms of the ERA study, which was an angiographic study, which had actually, the hypothesis was that it was going to actually prevent progression of atherosclerosis. It didn't show that benefit. And then we had the primary prevention trial, the Women's Health Initiative, which at the end of the day did not show cardiovascular benefit. There's been a lot about this trial, but at the end of the day, the majority of women were about 20 years post-menopause, and there wasn't a benefit from the cardiovascular point of view. So in 2004, the first evidence-based guidelines were published, and this new research now showed that hormone therapy was no longer a viable preventative treatment. The next important thing that came out of these guidelines was a concept called the Global Risk Assessment concept. And what they did here was they combined the Framingham risk scoring together with the National Cholesterol Education Program Adult Treatment Prevention. And what it actually does is you group patients into high risk according to where their Framingham global risk is, and the clinical examples in terms of it was the high-risk patients where patients had established disease. You then had intermediate risk where it was actually a variety of risk factors going down to low risk and optimal risk. In 2007, we had the third update, and this third update was really to place emphasis on preclinical detection to identify asymptomatic individuals who could benefit from early intervention. So despite all the evidence that we have, why isn't cardiovascular mortality declining in women? Here I'll show you figures from the US, and you will see over a 20-year period in the red, mortality rates in women are going up, whereas in men they're going down. This is from Europe, 2008. Where they state cardiovascular disease is the main cause of premature death in women. In populations under the age of 75, 42% of women die compared to 38% of men. So what is the problem? Is it the Yentl syndrome? Now, for those of you who don't know, the story of Yentl was actually written by a Nobel laureate in literature, Isaac Bashevis Singer. And the story went that Yentl had to actually go ahead and disguise herself as a man to attend a school of religious studies. And Bernadine Healy in the US, a cardiologist there, actually used this term in 2001 to call attention to this paradox of adverse outcomes of women with ischemic heart disease. That was 2001. We go to 2011, and the bottom reference actually comes from the European Heart Journal from last year, that the Yentl syndrome is still alive and well. So what are the problems that we're dealing with? And I'm not going to go through all of them, but I'm going to touch on the Framingham risk scoring, because one of the problems we had with the Framingham risk scoring was an underestimation of risk. If you look at the lifetime risk of women, as shown here, and you'll see on the bottom, age going up to 70 to 79, even in that age group, very few women are at high risk, and that is actually shown here by the red bar. Very few women actually qualify as having disease. In this study from the US, which was women under the age of 65 who had myocardial infarcts, if you had risk stratified them before they had their infarct, none of them qualified. In fact, 95% of them were considered low risk, and 82% of these women would not have been eligible to actually get pharmacotherapy as was advised by the guidelines. So last year there was a new update. This was now the fourth update, and they've changed it. They've called it the Effectiveness-Based Guidelines for the Prevention of Cardiovascular Disease. And what they've actually done is they've changed the rating in terms of risk in women. It was updated in 2008. So if you take a 63-year-old woman who has a total cholesterol of over 7.2, she has a low HDL, she's a smoker, she had raised blood pressure untreated. In 2007, she would have had a risk of 17%. She wouldn't have qualified for therapy. But in 2011, we now accept that she actually is a high-risk patient. In South Africa, we are actually associated with the European Society of Cardiology and the Atherosclerosis Society. And they've actually updated their guidelines, and this is in terms of dyslipidemia, but you will see the way they've done it is the same as Framingham, putting patients into high risk or very high risk. Those who've got established disease, diabetes or chronic renal failure. Our high risks are if they've got a single risk factor, and then moderate risk. And all of us know these risk factors. But I've highlighted in yellow an important new risk factor that's been included for women. That's of chronic inflammatory conditions. What has been shown that women who have these conditions actually have a high risk of cardiovascular disease. The American guidelines are actually very similar. They've also included this category of patients who've got systemic autoimmune collagen vascular disease. But they've included another category now, which is important for the obstetricians, because what has actually happened is we now know that women who have an obstetrical history of preeclampsia, gestational diabetes, or pregnancy-induced hypertension are also high-risk patients. So when we speak to our women, we need to actually focus on this as well. And the importance of these actual classifications is our targets for treatment. If you have a patient and you're treating them for cholesterol, our very high-risk patients, we want them treated to an LDL of less than 1.8. In the high risk, we're going down up to 2.5 of LDL, and those of moderate risk to less than 3. So finally, I want to just show you about modifiable risk factors. There are 10 of them here. I'm going to highlight 6 of them. And these 6, I want to show you data from South Africa. Please note that this data was from country surveys in 1998 and 2003. So in terms of hypertension, this data tells us that 24.6% of our women over the age of 15 have hypertension. If you survive to 65 years, it's 42.5%. In terms of tobacco use, it's 10.2% of women over the age of 18. In terms of diabetes, it increases with age. By the time you're 68, it's about 9%. Look at this figure for physical inactivity. And this is going back to 2003. 46.6% of our women are physically inactive. So it's not surprising when we look at overweight and obesity that we actually rank as one of the capitals of obesity in the world. The figures of women over a BMI of 25 is 56.2% of our population, and for class 1 obesity and above is 30%. In the light gray, I've given you the worldwide figures. And in terms of high cholesterol, the figure we were given is 2.8%. But please note that these surveys from that time did not include our ethnic groups besides Caucasians. So that figure is actually incorrect. So what is the take-home message for us today? What is the optimal risk for women? Our optimal risk in terms of screening is a cholesterol, total cholesterol of less than 5.2, a normal blood pressure less than 120 over 80, fasting sugars less than 5.6, a BMI of less than 25, of course abstinence from smoking. In terms of our patients who are physically inactive, they only need to do about 150 minutes of exercise a week. It's not a major amount. And of course a healthy diet. So finally, ladies and gentlemen, in terms of our understanding of women, we've come from no evidence base to this. Thank you very much.